So we built really a payer-centric platform that allows them to log into the client portal to see exactly how the program is performing at any given time in real time. We are growing company. We are seeing new opportunities, and we're getting more and more requests from health plans to do more and more in-home.
Richard, thanks for hopping on today's podcast. And for the guests listening, we have Richard Pridham, President and CEO of Retina Labs, joining us today. Richard, first off, well, thank you for making some time to speak to me today. Curious, what led you to start Retina Labs, and, what sort of need did you first see in diabetes care or larger healthcare overall that led you to kick things off with Retina Labs?
Yeah, and thanks, Bert, for inviting us. It's a tremendous pleasure. Yeah, I mean, Retina Labs was founded over a decade ago, really to solve, I think, an important healthcare problem around diabetic eye disease, or as we call it, diabetic retinopathy. The number one cause of blindness. It's a disease that's entirely preventable, and it affects about 60% of diabetics during the course of their lives. The clinical protocol is for diabetic people to get screened for diabetic eye disease at least once every year or 2 years. It's a situation where, this disease is a silent disease until it becomes problematic and affects your vision. Screening and early detection are really the key to, lower costs for health plans and better outcomes for patients. So this company was founded really around a mission to end preventable blindness caused by diabetic retinopathy by making screening for diabetic eye disease more convenient and accessible to patients, whether it's part of an in-home experience with a patient inside their home or in a primary care setting. So we built an entire platform around the diabetic eye disease workflow, which means image acquisition from fundus cameras, the interpretation piece, which is done through board-certified ophthalmologists that examine these retinal images and render a clinical interpretation, and of course the reporting of this information back to the patient as well as their care provider so that they can be either rescreened or referred as needed according to their condition.
Well, first off, the numbers are impactful around like you said, it's the number one cause of blindness, and it affects 60% of diabetic patients is diabetic retinopathy, which is basically like eye disease,
Correct. Yeah.
And you're saying the standard protocol is for diabetic patients to get screened once every year or 2 years. And who has skin in the game with screenings? It's the health plans, right?
Right.
And how exactly are health plans using your guys' model to identify these members that need the screening? And then what are some of the sort of outcomes that it leads to?
Yeah, so for one, I mean, the diabetic eye exam gap in care is a very difficult gap to close. So if you back up and you look at the HEDIS outcome measures, these are the outcome measures that drive star ratings for health plans. There's a whole section for diabetes care, and inside of that, you've got the measure for the eye exam for people with diabetes. It's a difficult measure to close because it involves a retinal eye exam. That means the patient has to go to, in a traditional setting, go to an eye care provider, an optometrist, ophthalmologist to get a fully dilated eye exam. Many people choose not to do that. Perhaps their vision is fine according to them. There's no need to go to get a dilated eye exam. Sometimes there are copays involved, travel, what have you. So, a lot of diabetics don't get this exam. If you look at the adherence rates for diabetic eye disease in the United States, they're less than 50%. And even in some cases and among some sociodemographic segments of the population, they're a lot less than that. So you've got, in the United States today, there's somewhere around 36 million diagnosed diabetics. There's another 90 million pre-diabetics. That, the population of diabetics expected to double. And you've got less than half of that population receiving these diabetic eye exams at the appropriate intervals. So the health plans obviously are aware of this and push down incentive programs to the primary care providers in their network to, get them to do the screenings. That's worked with some mixed results. There's capital equipment that needs to be purchased by the practice to do these exams. Some, want to make that investment, some don't. But the health plans realized that there's a model that they could take advantage of, and that's an in-home preventive care model. and working with us can allow them an easy way to close gaps in care on a very reliable basis. So the health plan will typically go into their systems and pull out what we would refer to as non-compliant members. These are members that have not had a diabetic eye exam done in any type of setting, whether they went to an ophthalmologist, an optometrist, or their primary care provider. So they would be essentially eligible to receive this in-home screening. And they would basically provide us with that eligibility data through our ComplyHub platform. It's done in a fairly automated basis. And we would engage with those members to essentially inform them that they are covered under their plan for an in-home preventive screening encounter where we could do the diabetic eye exams, and also coupling that with other preventive screening tests such as hemoglobin A1Cs, kidney health function, colon cancer screenings, bone density screenings. So for the health plan, they'll give us one list of non-compliant members, and we will essentially, go into those members' homes and carry out multiple screenings, closing multiple gaps in one single home visit, which makes a lot of sense for everybody. And the patients, they love it. They think it's a fantastic service, and our satisfaction scores are a testament to that.
That's an incredible model. So basically, beyond like the health plans partnering with you guys and saying like, hey, here are some of our like members that potentially may be like non-compliant, you guys travel into the home. Like you literally have like a fleet of, I assume these are like vehicles across various states that go into the homes of members and are screening them, doing these preventative screenings, which, by the way, this has been around in the industry for how long, right? Years, that these incentive mechanisms have been around for doctors, for providers. But like you said, which was really interesting, a lot of that sometimes requires capital equipment, and
That's
like
right.
a primary care physician may not want to do that investment because then they have to pass along the cost to their patient. However, with you guys, it sounds like you guys are able to go into the home and even potentially maybe the office for some patients that
Yeah.
aren't comfortable with that, right?
Yeah, I mean,
Uh,
we're working across all different lines of business for different health plans. Medicare obviously is a big driver because if you look at the quality incentive structure around Medicare Advantage programs, there's a lot of money on the line for health plans to improve their star ratings. And certainly, closing gaps in care is a big part of that. But we're also working with Medicaid populations. There are various state pay for performance bonus programs for state Medicaid programs. So there's money on the line for the plans in that respect, and commercial as well. So we're working with essentially marketplace members. These are people who are working, 9 to 5, many of them, self-employed or government employees in some cases. And, we've had our field workforce go into, their workplace to perform the exam, which we've really perfected the art of retinal image capture. We're using, essentially the latest, greatest technology as far as portable fundus cameras are concerned. Our techs are fantastic at that job, better than anybody else in the industry. We can get in and out of somebody's home or workplace in under 10 minutes. And, that's a real plus because it's not really a big time commitment for members. These are fully non-dilated eye exams, so we don't use dilation drops, which means that as soon as we are done, the patient can continue on with their day, and there's no impaired vision for a period of time after the exam. In terms of the field workforce, I mean, we have our own field workforce going around in those cars. I think many have seen them on the road, traveling to patient homes, whether they are in metropolitan areas in certain states or in those underserviced rural areas. That's a big part of the audience, is really servicing those members that are in distant parts of the states, rural care where they don't have an eye care provider in their area. But everything starts before then. We have our outreach team, so we've got a team of member outreach and scheduling experts and other tools that we use to engage with the members. And then, of course, schedule our field workforce to go into the homes of these health plan members at their convenience. And we also do a lot of events with health plans. That's turned out to be a really big opportunity for the health plan to close lots of gaps in care with members all in one shot. We do these events. I think last year we did over 100 events. These are events that take place in provider offices, community health centers, health fairs. And we sometimes will do 80 or 100 screenings in one day, and the health plan members love it because they can come in and get the tests they need to stay healthy.
right. Yeah. Yeah, I think that seems to be the case with a lot of these preventative screenings that are available to members and patients is like beyond education, right? Because there needs to be education. I'm sure that's a big part of why you guys go to these events. It's meeting them like almost where they are, right?
Where they
Because
are.
it's going to having for you to travel to go out of your busy like work day, right? To go travel to your physician's office to then do this preventative screening, it's something, it's an extra visit, but if you're able to do that in their home, even said their workplace too, which is really fascinating, there's a lot more buy-in and commitment that way. I want to talk to you about the technology specifically because I think
Yep.
that's fascinating as well. Why did you guys, I know you said you have like the latest greatest like technology with retinal image capture, but the like platforms that like work with that you guys have built in-house, I think you, from what we spoke about before, you made like maybe a strategic decision to like build two platforms in house. One is called like ComplyHub, which you mentioned earlier, and then iVision.
Yep.
Why did you decide to build those like in house specifically? And how do they support this like this care delivery model of meeting the member where they are?
Yeah, great question. Well, I mean, we started this company as a software company in the tele-ophthalmology space, right? So our iVision platform is essentially a store and forward cloud-based tele-ophthalmology platform that's really built to support the clinical workflows associated with chronic eye disease, not only diabetic retinopathy, but glaucoma, age-related macular degeneration, as well as retinopathy of prematurity that is, a huge problem with premature babies. So we built this platform that does everything that you would possibly want to do with respect to image capture and interpretation and reporting around chronic eye disease. When we started our in-home business in 2019, I mean, we were getting calls from health plans, interested in partnering with us to see if we could help them close gaps in care around diabetic eye disease. What they were asking us to do is to deliver this service on an in-home basis, and that was new to us. I mean, we didn't have any workforce at the time, any outreach. We had no technology to do eligibility, file ingestion for member targeting and outreach and scheduling and field workforce coordination. We had none of that, but we knew we needed it. So our first intuition was to look on the market. There are a myriad of what you would call home care management platforms. I think we looked at
Mhm.
every single one, and we were left with the feeling that there was nothing out there that would really, cater to the specific needs of in-home, care gap closure. So we decided to build our own. We're a technology company. It made sense to do it. And it took us about initially to get a V1 on the market. It took us a good 6 months. That was in, 2019, 2020. And that allowed us to do everything associated with the in-home preventive screening operation. So the outreach and scheduling and all those things, as well as reporting the data back to the health plan. So, we come from the mindset that, spreadsheets are to be forgotten. We don't want to be sending clients all kinds of spreadsheets about how their program is going. So we built really a payer-centric platform that allows them to log into the client portal to see exactly how the program is performing at any given time in real time. They could see the outreach effort, the conversion rates, how many members we've called, how many we've contacted, how many we've scheduled, how many exams we've completed. They could see the metrics around each of the different tests we offer, how many diabetic eye exams we've done, and even also look at the disease severity of diabetic retinopathy, the proportion of
Mhm.
cases that are early, moderate, severe, proliferative. So for all the different tests that we do, they can see those aggregate results, and they can also drill down and view the member results, the test results, the lab reports, the diabetic eye exam report, as well as all the member engagement touches that we've had with them, all at the, essentially their fingertips, so that they can keep, their finger on the pulse of the program. So it made a lot of sense to build versus buy. We're glad we chose that because it allows us an opportunity now as we are growing the company. We are seeing new opportunities, and we're getting more and more requests from health plans to do more and more in-home new tests, like we're doing blood pressure, we're looking at annual wellness visits, and all of these things have their own unique clinical workflows. And the fact that we own our own software allows us to really customize the workflow to support the needs of that specific test.
Yeah, I see. No, I mean that's fascinating. Especially the point you made on like there's so many home care management platforms out there. There's
Yep.
tons of them,
Yep.
and like it really sounds like you guys made a conscious decision to build in-house, right? Like you built out this platform that two platform, ComplyHub, iVision, and each of them work together in delivering these preventative screenings, and on this point about like the current market, out of curiosity, just like how many like markets are you guys in today, like across the US?
Yeah, we're working with a number of health plans. We're servicing about 20 states today. So we're heavily concentrated just because of the way the in-home business evolved. We're heavily concentrated on the East Coast of the US. So we're in Tennessee, we're in, Kentucky, Ohio, Virginia, West Virginia, Pennsylvania, New York, Massachusetts, Connecticut, as well as Ohio. So we've got teams in those states. We're expanding geographically by virtue of the pull from the health plans. So we're now expanding into states like Minnesota and Florida and Texas. So that's how we're growing the team. One of the decisions we made is to only utilize W-2 employees, whether we're talking in the call center or our field staff. There are other companies doing similar services, but they're using contractors. The quality
Mm,
of the work they do, the quality of the imaging is not quite as good. So we've decided that our approach is going to focus on W-2 employees. And every time we go into a new market, we'll stand up a team in that market. We'll train them and we manage them 100%, which means we have full control over their schedules. Whereas if you're dealing with independent contractors, let's say a nurse practitioner that's working for other organizations, your scheduling has to suffer. So that's
mm.
worked out for us very well. And I think in the end, it means just better results overall for the member, for the health plan, and for us.
Right. It's like you have that, like having those resources in house, I'm sure allows you guys to really, like you said, not just customize the workflows earlier, like we talked about, but also having those folks in house. When you get into a new market, I'm sure you guys have the model already of like, hey, yes, there'll be differences in the type of market we're catering to and the types of health plans, but this is the team we
Yeah.
need to staff to do this, right? And you guys know that because you have a lot of these folks in house instead of just relying on contracted
Yeah.
labor.
Yeah, and when we're standing up a program in a new market, for instance, I mean, typically we've demonstrated this time and time again, where within about a 4 to 6 week window, we can mobilize a team in a new market. We've developed some really great recruitment and onboarding and training tools and methods, which means that we could put somebody super qualified on the ground within about a 4 to 6 week window. So that's an advantage that we have. And we've been able to repeat it multiple times in different markets.
Clearly, yeah. This model makes a lot of sense to me. I think there's a big push happening in a lot of industries, but particularly in healthcare with in-home like care delivery, right? And companies are tackling this from many different angles, and it 100% makes sense to me and how where we're headed, where our populations of patients are headed. The boomers retiring here, the silver tsunami, whatever you want to call it.
Yeah.
But what sort of like challenges do you guys face when you expand into a new geography or you work with new health plans? Like for example, you said that a lot of them had said, "Hey, we want to go more into the home."
Yep.
Right? I'm sure they know exactly the types of preventative services, right, to tackle. But
Yep.
what comes for? Is it like, "Hey, we just don't know what type of populations a patient, which patients to narrow in on." We sort of know like, okay, there's these three screenings we really need to focus on for in-home
Yep.
visits. Can you help us like narrow in on those patients? Like what's the challenge
Yep.
you guys like try to expand into a new geography or market?
The part about the health plan, I mean, the nice thing about what we've developed with ComplyHub and our general model is that it's not a one size fits all approach. So the health plan, we can customize a program for a health plan, number one. Number two is that they can specify what gaps need to be closed on a member by member basis. So there are members, for instance, that are all they need is a diabetic eye exam. So, that's all they'll get. Some of them will need a diabetic eye exam and let's say a kidney health or an A1C lab test. So we'll be able to get that done. There are some members that just need a lab test. So we have another part of our business where we will mail out those test kits to members. They'll get them in home and, they could, self-administer that test and essentially send the specimen back to our lab. So, we can really customize the program for the plan. And in terms of setting up in a new market, I mean, the big challenge is just the critical mass of population that we're dealing with. So, generally speaking, if a plan has at least 3,000 open gaps for a diabetic eye exam, that gives us typically the impetus to staff that state. And sometimes it could be as simple as one technologist that will work that state and travel across the state. In other cases, if it's a larger population, we'll staff more people as needed. And we also have the ability to augment staff in a given market by having some of our techs that do like to travel to other parts of the country. We can stand them up, for extended periods of time in a given market. So I think the flexibility is a big advantage in dealing with us.
Yeah, interesting. Is this like a chicken and the egg situation where, like, in terms of the care gaps, it sounds like that's the key, right? Like, you guys really can customize a plan around care gaps. Do these health plans know how many members have care gaps ahead of time, or is this data you guys are able to then extract for them, you know?
Yeah, the health plans know about their open gaps, that's for sure. I
Right.
mean, it's easy for them to, pull that data, from their
Mhm.
various systems to see, what that non-compliant population looks like. So, but we do work with them in terms of facilitating that process, in also structuring the data feeds so that we can get that data in a way that we can automatically ingest it. So we've got plans that are sending us literally data feeds every single day because their population, the number of eligible members for the different screenings that we do can vary. As you have members that fall off a health plan, you have members that completed a diabetic eye exam or a preventive screening somewhere else, so they can remove them from our
Yeah.
population as well as new entrants to the non-compliant population. So we've got plans that can, send us data feeds every single day. Some do it weekly, monthly, or more on a periodic basis. But the fact that they can just literally update their data and refresh it, and we can, on a dime, we can, focus on that population
Mm.
without retooling anything. I mean, it's just part of our process. We've built some really fantastic tools, what we call member targeting tools. So when you look at the population in a given state, if you've got, 60, 70,000 members that you've got to chase after, how you target that population in that state to reach everybody in the urban areas, in the rural areas over the course of the year, how you get to everybody and do it in a manner that is efficient, right? So we want to make sure that the routes of our field staff are logistically coordinated such that they can go out in a day and do the maximum amount of screenings and home visits. That takes a lot of know-how and technology, and we've built a lot of that technology, and that's really, I guess, part of our secret sauce.
Yeah. No, I mean, it certainly sounds that way because, and not to downplay the role like health plans play. I know they have access to a lot of data. I've worked with these health plans too, but it's just like the question that comes to mind is like, why aren't like more of them tackling these care gaps? They know they
Yeah,
have care gaps, right? And is it a matter of just like prioritizing, which you threw out a few earlier, like diabetic eye exams, kidney health, like A1C levels, lab tests? Is it just a matter of like prioritization, or is it like finding the manpower, or like you said, the technology partner that can like
yeah.
help enable, like, operationalize it, you know?
Yeah, I think there's a few things there. One is obviously, whether or not they know of us. That's the first thing. Some of them, when there's amazing conversations we've had with some health plans, even recently, that they didn't know us 6 months ago. And when they found out about us, they were like, "Where have you guys been? I've been looking for a company that can do this the way you guys are doing it with a technology-enabled capability. Like, how did I not know you exist?" So we're trying to address that through our marketing efforts, and we're certainly present at all the health plan trade shows, but sometimes the message doesn't get through. The other thing too is the underlying philosophy of the health plan. There are some health plans that feel that their model is best if it's primary care centric, which means they want to do everything at the primary care level. So get the providers to do all the gap closures. Just download everything on the provider, incentivize the provider to do this. It
Hmm.
doesn't always work. It doesn't always work. If you look at some of the rural areas in a state, those primary care providers don't exist in some cases. So, we bring a whole fresh perspective on how to do this, how to do it well, and it's not necessarily at the expense of primary care providers. We're doing it to help primary care providers because if you have a health plan member that is attributed to a primary care provider and we close the gap, the primary care provider will get the credit for it. And we do, as I mentioned earlier, we're doing events. A lot of those events happen in those provider offices.
Hmm.
So, we'll just take, for instance, Franklin County in Tennessee. We'll target members that are attributed to a given primary care practice. We'll contact all those members, get them to come to an event inside of that primary care practice. So they'll come in, they'll get their diabetic eye exam. They could even be seen by another provider in the clinic while they're there. And it's great because the primary care practice got a whole bunch of diabetic eye exams done at no cost to them, and they get full attribution for it as far as their quality bonus payment. So, I think we're very, very provider friendly in that respect.
Hmm. Yeah. No, I love how you guys have established this model that brings like the health plan, the member, and the provider together. Because
Together. Exactly.
that that logically came to mind to me when you were. I was going to ask you like, what's the flip side, right, for health plans? Like, and it's you answered it in saying like, well, a lot of health plans think it has to be primary care centric, right? But you brought up this good point that doesn't always work in all the geographies. You have rural
It
areas
doesn't.
where there's not an access to a primary care physician. You
Exactly.
know?
It's
So
exactly it.
yeah,
It's exactly it. And even if there was, sometimes, that provider may not be interested in investing the capital equipment to buy the retinal camera and offer the exam and so on. So, I think it's a win-win-win for everybody involved, including the
yeah,
providers.
absolutely. What is next for Retinal Labs and the team, and how can like interested like health plans partners, potential partners listening to this like connect with you and your team, whether it's like a new care gap they want to close or a new patient population or member
Yeah.
population, excuse me. Like what's next for you guys, and then how can those interested parties like connect with you guys?
Yeah, so we're driven by the growth of the company. We've had since over the last 3 years over 500% year-over-year growth. The company's has performed financially very well. That's allowed us to reinvest in terms of development of new products, and bring new people on board. So we're continuing on that path. We're expanding into new markets, as I mentioned earlier. I mean, our goal is to be by the end of 2026 to be, a national provider, have a presence in all major markets. So we're on track for that. The other thing, as I hinted at earlier, is expanding the portfolio of services we offer in home. And we've spent a lot of effort doing the outreach, the engagement, getting, a technologist into the home of the patient. What else can we do? And what we're hearing from health plans is that there's a fairly exhaustive list of things that they'd like us to do. Social
Hmm.
determinants of health, pain medication, pain management reviews, wellness assessments. Like I said, we're just teeing up blood pressure now. We're going to be doing that as well. So there's more and more that we can do in home, and that's where we're at today and where we're headed.
Yeah, I mean, are employers part of that mix? Out of curiosity, right? Because employers are oftentimes have like plans with these health plans, right, with all their employees, right? And what's the model for them? Because they need to have these preventative services in place for a healthier employee mix, right? Is that part
Yeah.
of something you guys have looked at?
Well, we're touching that population, as I mentioned, through the health plans, through their commercial and marketplace populations. But going after the self-funded employer groups is something that's sort of on the radar screen. We've been looking at that. There are some large companies that have chosen to self-fund their health insurance. And of course, they need to provide all the amenities around that, which include preventive screening. So that's something that, we're going to be looking at. But right now, the focus has been partnering with, Medicare, Medicaid, and commercial health plans. It's a market that we understand. We've built the tools for it. Some of the other things that we'll be building out are, some AI-based scheduling tools. Self-scheduling is something that we're teeing up to allow members to self-schedule a logistically efficient appointment, at least logistically efficient for us. So those are some of the things that we'll be looking at as we get into 2026. Yeah, in terms of it, engaging with us, I mean, we're, as the old saying goes, a phone call away. You could visit our website. It's Retina, Retina dash labs, labs.com. There's lots of materials there, case studies. Anybody could request a demo, and we can certainly tee up a conversation to talk to any health plan about closing gaps in care. So yeah, it's we're just a phone call away.
Yeah, I love that. Make it easy on folks to find you. And
Exactly.
and those case studies, I will definitely do a deeper dive on, and may try to link one or two of those in the comments below for folks to look at, because I think the
Yeah.
work you guys are leading is very not just beneficial for members and the health plans that they're a part of, but something we need in the industry overall, to improve access to preventative screenings and care,
Yeah.
right? That's the way you do early interventions, you find things early,
Yeah.
right, for patients. And so without the right technology partner,
Yeah.
a company that like yours that can mobilize that for health
Yeah.
plans,
Yeah.
their options are essentially limited to primary care from what I've learned from
Yeah.
this conversation, and yes, that works in some geographies, but for all geographies, the question is, does it work? And what I've heard from today's conversation is no, like this is why health plans end up partnering with you
Yeah.
guys. So
And health plan members are coming to expect this home care model. The traditional model of the brick and mortar doctor's office. I'm not saying it's disappearing, but it's not what it used to be. It's not the only place where a
yeah,
care and preventive care can be provided. And members more and more are expecting care to be brought to them where they are at their convenience. And just to touch on one other thing that you mentioned, in terms of our company culture, the doing good part of this is really a key aspect of it. We're a business, nobody's going to deny that, but we're providing a public good. We're bringing preventive health, important preventive health. We're saving vision, and many of those people would otherwise not have access to that care. We're bringing it to them where they are at their convenience. And I think the members really, really appreciate it. So for the health plan, it is a huge, huge, huge loyalty and satisfaction driver.
right, yeah. And I think providers are starting to come around the corner with that too. With there's big pushes for like virtual nursing, large
Yep.
health systems. Like I think primary care, it'll trickle down to them as well, right? And
Yep.
they need to provide better access to this even in the patient's home. For a lot of patients that don't have the bandwidth or time to go into
Yep.
the brick and mortar office every time. So
Exactly.
yeah, no, I truly appreciate the mission you guys are leading, and 100% will keep tabs on your guys' journey. And it was a pleasure speaking to you today, Richard. And yeah, looking forward to staying in touch here. And thanks for hopping on today's podcast.
I welcome the opportunity to speak. Again, this has been great. Thank you very much and have a great day.